Hello, and welcome to NCCN's Global Policy Webinar series looking at individual health and the cancer burden globally. My name is Crystal Denlinger, and I'm the Chief Executive Officer of NCCN. I welcome all of you today to this important discussion. NCCN is an alliance of leading cancer centers across the United States. We have 33 member institutions who are devoted to patient care, research, and education. And as you can see, we have both geographically diverse institutions as well as various types of cancer centers across the country. And at the beginning of 2025, the NCCN Clinical Practice Guideline Library encompassed 88 clinical practice guidelines featuring 228 algorithms that applied to 97% of cancer cases in the United States. This library includes 66 guidelines dedicated to cancers specifically, 12 guidelines dedicated to supportive care, 7 guidelines dedicated to cancer detection, prevention, screening, and risk reduction, and 3 guidelines dedicated to specific populations that have specific needs in cancer care. In 2024, we had over 2 million registered users of NCCN guidelines and over 16 million downloads across the library of clinical practice guidelines. When we look at this globally across the United States, almost half, or approximately 1 million of our registered users are outside the United States. And when we look at the number of downloads, there were more than 7 million downloads across 190 different countries outside of the United States. And as you can see from this heat map, there are some differences in the number of downloads, and this is primarily due to differences in the number of oncologists in a given region, not necessarily related to guideline download activity. As we start to think about today's topic, I wanted to highlight some important clinical and patient resources that NCCN has to support busy oncologists and healthcare providers in addressing some of the health-related topics that we're going to discuss today. Because smoking is one of the biggest risk factors for cancer, as well as a risk factor for poor outcomes in people diagnosed with cancer, NCCN has developed a clinical practice guideline on smoking cessation, and later today, you'll hear from Dr. Peter Shields, who is the chair of that guideline. We also have a survivorship guideline, which addresses survivorship issues as well as health behaviors for people who have been diagnosed with cancer and who have completed their treatment. Many of the topics in this survivorship guideline also apply to those people living with metastatic disease and can be applied to those patients as well. And we look forward to you interacting with these resources at the website below. We also recognize that it's not just our clinicians who need good resources on smoking cessation and survivorship, but also those people who are diagnosed with cancer and their caregivers. And so NCCN has developed patient resources that can be utilized for those who are dealing with these issues. We have a guideline on quitting smoking, as well as a guideline dedicated to survivorship care for healthy living, as well as one for late and long-term effects. Both the quitting smoking guideline and the survivorship care guideline for healthy living are available free of charge for download and present the same recommendations that our clinicians see in a patient-friendly lay language way that can be used by our patients and caregivers along their journey. NCCN appreciates and recognizes the following supporters of today's webinar: B1 Medicines, Johnson & Johnson, and Regeneron Pharmaceuticals have provided funding and sponsorship for today's webinar. Today's agenda is quite jam-packed, and we're excited about today's meeting. Our first address will be a keynote looking at reducing cancer morbidity, mortality, and other disparities through lifestyle changes. And then we will hear a keynote address specifically looking at cancer and alcohol, looking at these sobering statistics. And this is important because while we know that tobacco use has long been associated with carcinogenesis, there's been more recent data looking at cancer and alcohol, and this important topic needs to be further brought to awareness in the public. Finally, we're going to have a panel discussion in which our speakers will join for a discussion about how to improve awareness and how to decrease morbidity and mortality from cancer through individual health. Our moderator for today's session is Katie Winkworth-Prejnar. Katie has been with NCCN for a number of years and joined in 2016 as the Policy and Advocate Fellow. She's currently the Senior Manager of Global Policy and Strategic Alliances, where she manages our global network of official collaborators, as well as collaborations with organizations that share aligned missions and global priorities for the implementation, adoption, and endorsement of evidence-based care. Prior to joining NCCN, she worked at Drexel University and received a Master's of Public Health with a concentration in global health from Drexel University Dornsife School of Public Health. Our first keynote speaker is Dr. Farhad Islami, who is the Senior Scientific Director, Cancer Disparity Research for the Surveillance and Health Equity Science Division of the American Cancer Society. Dr. Islami leads the Cancer Disparity Research Team at the American Cancer Society and primarily conducts translational research to identify individual, social, biologic, structural, and system-level determinants of health, and to estimate the contribution of each to cancer disparities. His work informs cancer delivery and public policy, and he also conducts and collaborates on research focused on cancer surveillance and risk factors. His work has demonstrated the association between drinking hot tea and esophageal cancer risk. He's been named to the Altmetric Top 100 list of academic papers that received the most online attention in 2019 globally. He also has served as a member of the International Agency for Research on Cancer team and participated in multiple monographs and handbooks. Our next keynote speaker is Dr. Beatrice Lauby-Secretan. Dr. Lauby-Secretan joined IARC, the International Agency for Research on Cancer, in 2001 as a postdoctoral fellow, and then took a position within the IARC Monographs program as a scientist, and ultimately became responsible for the monograph section on exposure assessment. She then was selected in January 2014 to lead the relaunch of the IARC Handbooks of Cancer Prevention program within the section of IARC Monographs. She has a bachelor's and master's in biochemistry from the University of Geneva in Switzerland, and then a PhD in toxicology from London, United Kingdom, as well as 2 postdoctoral positions, but one at the Harvard School of Public Health in Boston and one at the University of California in Los Angeles. And with that, we'll turn to our first keynote.
Good morning, everyone, and thank you for joining. My name is Farhad Islami. I'm Senior Scientific Director at the American Cancer Society. Today, we'll be discussing the global burden of cancer attributable to potentially modifiable risk factors and associated disparities, and how this burden can be mitigated by reducing exposure to risk factors and lifestyle changes. First, I have no conflicts of interest to disclose. Here is an overview of this presentation. I will start by talking about the global burden of cancer from modifiable risk factors, and then provide more information about key risk factors, including tobacco, excess body weight, diet, physical inactivity, and infections, followed by conclusions. Some of the information that I'm showing in this presentation are from these 2 great resources that are produced by the American Cancer Society in collaboration with the International Agency for Research on Cancer. The Cancer Atlas has just been updated, and the website and print copy will be launched later this month on June 25th. Cancer is the second leading cause of death globally. In 2022, there were 20 million new cancer cases and 9.7 million cancer deaths worldwide. About half of these deaths are linked to modifiable risk factors, indicating that many cancer cases and deaths can be prevented by reducing exposure to risk factors. Cancer is expected to surpass heart disease as the leading cause of death in every country in this century if current trends continue. This slide shows the global cancer burden attributable to potentially modifiable risk factors. Tobacco use is the leading preventable cause of cancer death, contributing to 6 26% of all cancer deaths globally, meaning that about 26% of all cancer deaths are attributable to tobacco use. About 6% of all cancer deaths globally are attributable to dietary factors, 5% to excess body weight, and 5% to alcohol consumption. This study didn't provide information on the proportion of cancer death attributable to infections, but another study estimated that about 13% of all incident cancer cases globally are attributable to infections. There are some other important modifiable risk factors that I do not cover in this presentation. For example, skin melanomas attributable to UV radiation constitute about 1 to 2% of all cancer cases globally. But this percentage is much higher in certain regions, about 4% in North America and close to 10% in Australia, meaning that 10% of all cancer cases in Australia are skin melanomas attributable to UV radiation. Tobacco smoking contributes to 2 million cancer deaths each year. About 60% of these deaths are lung cancer deaths. Esophageal cancer contributes to 10% of smoking-related cancer deaths. An additional 120,000 oral cancer cases have been attributed to smokeless tobacco use. This map shows incidence rates of lung cancer among men, showing a wide variation in rates across countries. Countries with the highest rates shown in dark red are generally located in Europe, especially Eastern Europe, and in East Asia. Countries with the lowest incidence rates shown in dark blue are in Sub-Saharan Africa. I should note that the contemporary lung cancer rates reflect smoking prevalence a few decades ago, say 30 years ago. So the ranking of countries in terms of lung cancer burden in the future may change based on their current smoking prevalence and tobacco policies. For example, lung cancer incidence rates in many sub-Saharan countries currently are in the lowest category, and the rate in Indonesia is in the middle category. But as shown in this map of smoking prevalence among men in 2022, some of the African countries are not in the lowest categories of smoking now, and Indonesia has one of the highest smoking rates in the world. This suggests, for example, that Indonesia is likely to have one of the highest lung cancer incidence rates in the coming decades if smoking prevalence is not reduced substantially. Please also note that in the majority of countries, cigarette smoking prevalence among men remains high, for example, from 25% up to 60 to 70%. Among women, lung cancer incidence rates are highest in North America, Europe, Oceania, and China, and are lowest in Sub-Saharan Africa, with a large difference in rates across countries, ranging from less than 1 per 100,000 population to 35 per 100,000 population. No need to say this difference is largely due to differences in smoking. The good thing is that smoking prevalence is declining in a large majority of countries. In this report by WHO, of 165 countries with sufficient data, 150 had declining trends and only 6 showed an increasing trend. In none countries, the trend was stable. However, because smoking prevalence is still high in many countries, to save more lives, it's important to reduce smoking in all countries and accelerate the pace of decline in countries with declining trends. Similar to many other high-income countries, smoking in the US substantially increased in the first half of the 20th century, as indicated by the black line in this figure. Current smoking prevalence in US among men peaked in the 1950s and remained relatively stable through the early 1960s, but the prevalence in women peaked in the early 1960s. The first US Surgeon General's report on smoking and health was published in 1964, which increased awareness about adverse health effects of smoking and was followed by tobacco control interventions. As a result, current smoking prevalence in both sexes saw a sustained and substantial decline from 1965. We usually see a lag period between changes in smoking prevalence and associated cancer burden, and as a result, as shown by blue lines, lung cancer mortality rates in the US started to substantially decline from 1990 in men and from 2002 in women. We recently estimated that as a result of declines in lung cancer mortality rates in the US because of tobacco control, during 1970 to 2022, about 3.9 million lung cancer deaths were averted, and 76 million years of life were gained because of this progress. This is a powerful example of how policy and behavior change can save lives. In many low and middle income countries, the increase in smoking prevalence started later than in high income countries, and the increasing trend continued until more recent years. This graph shows that smoking prevalence among men in China increased by the mid-1990s and then started to decline. This decline happened after implementation of tobacco control policies in China. I should note that despite declining trend, smoking prevalence among men in China remains high. The WHO's Empower framework is a comprehensive tobacco control strategy. It emphasizes monitoring tobacco use, smoke-free laws, cessation support, warning labels, advertising bans, and taxation. Although taxation is shown at the end, increasing the price of cigarettes through excise tax has been the strongest policy to reduce smoking in the US and many other countries. Of note, tobacco taxation usually has a stronger effect on smoking among teenagers and people of lower income. Cessation support include quit lines and providing cessation counseling and medication, as well as promoting access to these services. WHO has the Framework Convention on Tobacco Control, or FCTC, where member countries commit to reduce smoking by implementing evidence-based interventions suggested by the framework. This figure shows the percentage of countries that have comprehensively implemented select interventions overall and by WHO region. Although there are variations across regions, the percentages are generally low, indicating that much more can be done to further reduce smoking. Another important issue is that in countries with substantial reduction in smoking, like the US, not all groups have experienced progress against smoking at the same magnitude. For example, the prevalence of smoking in the US is about 4 to 5 times higher in people of lowest education levels, shown in red, than highest education levels, shown in dark blue. So it's not surprising to see that lung cancer mortality rates in people with the lowest education levels, shown in red, are 4 to 5 times higher than in people with the highest education levels in both sexes. Similarly, in all high-income countries, we see a higher smoking prevalence and associated cancer burden in people of lower socioeconomic status. However, this pattern is not limited to high-income countries only. As shown in the figure on the left, in many low and middle-income countries, smoking prevalence is higher among people with lower education levels. In many other countries, the point estimates are also higher among people with lower education, but the difference is not statistically significant. This pattern shows that by substantially reducing smoking among all individuals, disparity in smoking-related cancers can also be reduced. There are also variations in smoking by geography, which can be in part because of differences in socioeconomic status. In the US, however, many tobacco control policies are decided and implemented at the state level, so differences in policies are a major contributor to differences in smoking prevalence across states. States with the highest smoking prevalence in the South and Midwest, shown in darker blue in this map, have generally had weaker tobacco control policies than other states. Again, it's not surprising to see that pattern of lung cancer mortality follows that of smoking prevalence. This map shows lung cancer mortality rates by U.S. congressional district, and we can see that rates in the highest category, usually in the South and Midwest, is several times higher than the lowest category, about 61 to 98 deaths per 100,000 population versus 20 to 32 deaths per 100,000 population. Now let's shift to another major category of modifiable risk factors: excess body weight, poor diet, and physical inactivity. Excess body weight causes 440,000 cancer deaths annually. This number for dietary factors is about 600,000 deaths, and for physical inactivity is about 65,000 deaths. This map shows that among men, prevalence of excess body weight, defined as BMI of 25 or higher, which includes both overweight and obesity, is high everywhere. Although there is a wide variation in prevalence ranging from about 7 to 90%, the prevalence in about half of all countries is 50% or higher. And even in the category with the lowest prevalence, there are countries with about 20% prevalence of excess body weight. Among women, prevalence of excess body weight is even higher, ranging from 12% to 94% across countries. Obesity is rising globally because of changes in food availability, especially less expensive, calorie-dense foods, as well as declines in physical activity. The increase in obesity, defined as BMI of 30 or higher, started earlier in the WHO regions of Americas, Europe, and Eastern Mediterranean, as indicated with much higher prevalence compared to other regions in 1990, shown in blue. From 1990 to 2022, prevalence of obesity substantially increased in all regions. Physical inactivity is also widespread, especially among adolescents. More than 30% of adults and more than 80% of adolescents globally have insufficient physical activity, defined as less than 60 minutes of moderate to vigorous intensity physical activity per day. Because individual behavior choices are often occur within the context of the community, promoting healthy weight, diet, and physical activity will require both individual level and community level interventions with a comprehensive multi-sectoral approach. For example, it's important to increase awareness because some people may not know how weight, diet, and physical activity can affect their health and what they should do or eat to prevent the adverse effect. Food labeling is important to help people know what they are consuming. A very important issue, especially for under-resourced individuals and population, is to increase healthy food availability in terms of both accessibility and affordability. Healthcare providers can also play an important role, as usually people are more likely to follow their doctor's health advice than other people's advice. Setting some standards can also help improve the nutritional quality of the food supply. Successful implementation of these interventions and policies needs the engagement of different sectors, from health system to education systems and so on. Many countries have implemented some standards to reduce unhealthy food. Just as an example, 53 countries implemented best practice trans fatty acid policies as of 2023. Trans fat can increase weight gain and abdominal fat deposits. At the 78th World Health Assembly in May this year, 4 countries were recognized for their efforts in eliminating industrially produced trans fats from their food supplies. I should note that some intervention may work better in some population than others. So intervention should be selected based on their potential impact, feasibility, accessibility, affordability, and scalability at that population. So to achieve impact at the population level, it's important to prioritize intervention based on national or population level priorities, and then identify and agree on solution, communicate and engage with partners and stakeholders, implement the selected intervention and track progress and adjust, and sustain changes to support long-term progress and expand the knowledge and capacity. Following the 75th World Health Assembly in 2022, a series of intercountry dialogues were convened with 28 frontrunner countries in the 6 WHO regions. This collaboration will helpfully provide more information about how to promote a healthy weight, diet, and physical activity globally. This figure shows the number of countries that have prioritized and selected interventions that are likely to be more relevant to their populations. For example, 10 countries chose to integrate obesity management in their health delivery systems, but only one country selected providing subsidies for healthy foods. This slide shows WHO's Health Services Delivery Framework for Prevention and Management of Obesity, including primary, secondary, and tertiary prevention, in which all healthcare providers can be involved. The goal is to prevent progression of people with healthy weight to the at-risk group for obesity, to prevent progression from the at-risk group to obesity, and to prevent progression to severe obesity complications and comorbidities. The US CDC has also provided extensive guidance for promoting healthy weight, diet, and physical activity in schools and so on. It also provides recommendations to state governments, communities, healthcare providers, and the public. For example, some of the recommendations to healthcare providers include counseling patients about nutrition, physical activity, and optimal sleep, connecting patients and families with community services to help them access healthy food and ways to be active, and discussing the use of medications and other treatments for excess weight when needed. Infections cause 2.3 million cancer cases each year globally. The infections with the highest cancer burden include Helicobacter pylori, causing gastric cancer, human papillomavirus, or HPV, causing several urogenital cancers, and hepatitis B and hepatitis C viruses causing liver cancer. As shown in this figure, about 12 to 13% of all cancer cases globally are attributable to carcinogenic infections, although this proportion varies across regions. For example, this proportion is more than 25% in sub-Saharan Africa. One of the important carcinogenic infections in sub-Saharan Africa and many other regions is HPV infection, which is shown in green in this figure. Because of the limited time for this presentation, in the next few slides, I will only talk about the two infections for which effective vaccines are available: hepatitis B virus and HPV. For hepatitis B virus, countries with the highest attributable burden, shown in dark green, are in East Asia and sub-Saharan Africa. But as we can see on this second map, the lowest prevalence of HPV vaccination, shown in light and dark red, are usually in sub-Saharan Africa, an area with the higher burden of cancers associated with this virus, indicating the need for increasing hepatitis B virus vaccination in this region. This map shows the proportion of all cancers attributable to HPV infection in all sexes combined by country. Most countries with the highest proportions, shown in dark green, are in sub-Saharan Africa and in South Asia. Focusing on HPV-related cancers in women, this map shows that countries with the highest incidence rates of cervical cancer, shown in red, are generally in sub-Saharan Africa. An important intervention to reduce the burden of cervical cancer is screening, because it not only can reduce the cervical cancer mortality, but can also reduce cervical cancer incidence, because precancerous lesions can be identified during the screening and then treated, preventing the cancer. As shown in this map, however, cervical cancer screening is generally the lowest in sub-Saharan Africa and South Asia, regions with a higher burden of cervical cancer. As another important intervention, HPV vaccination can reduce HPV-related cancer among the vaccinated individuals, but the prevalence of vaccination is low globally, including in sub-Saharan Africa and South Asia, again, regions with a higher burden of HPV-related cancer. For example, only about 30% of girls in sub-Saharan Africa had received one dose of HPV vaccine in 2019. These are the WHO Cervical Cancer Elimination Initiative's 2030 targets, including 90% vaccination of girls by age 15, 70% cervical cancer screening, and proper treatment for at least 90% of women with cervical cancer globally. Despite great progress, as I showed in the last slide, much more should be done to achieve these targets. In summary, a substantial proportion of cancer cases and deaths are attributable to potentially modifiable risk factors, and prevention is the key to reducing the global burden of cancer. Because individual behavioral choices often occur within the context of the community, prevention will require both individual level and multi-component interventions at the community level with the engagement of public, private, and community organizations and further political commitment from governments. Tailored interventions are needed to promote healthier lifestyle across populations, including populations that are historically marginalized. At the end, I know that I showed a lot of data, but what I want all of us to remember from this presentation is that large share of cancer, including up to half of all cancer death, is potentially preventable through lifestyle and policy changes, and these changes have the potential to reduce disparities in the burden of cancer across and within countries. And thank you very much for your attention.
Good morning, good afternoon, and good evening. So first, I'd like to thank the organizing committee for giving me the opportunity to present at this webinar today. I apologize for not providing a pre-recorded presentation, but I'll make sure I'll keep to the time. Okay, my presentation today will comprise in two parts. I'll first give an overview of the association between alcohol and cancer and the burden of alcohol-related cancer worldwide. And then I'll present the IARC program and the most recent volume 20 on alcohol control. So the carcinogenicity of alcohol has been known since long. In fact, in 1986, the IARC monograph programs evaluated consumption of alcohol as carcinogenic to human group 1. And this was based on sufficient evidence for an association between alcohol and cancer at 5 organ sites. Later volume of the IARC monographs in 2010 and 2012 increased this list to 7 organ sites. Also in these later volumes, it was concluded that ethanol in alcoholic beverages is carcinogenic to humans, and that acetaldehyde associated with the consumption of alcoholic beverages is also group 1 carcinogen. And we'll see later why. The consumption of alcoholic beverages causes cancers of the oral cavity, the mouth, the pharynx, the larynx, the voice box, the esophagus, also known as the food pipe, the liver, the colorectum, and last but not least, cancer of the breast. The evidence for an association with cancer of the pancreas, which you can see here in yellow, was limited at the time of the last monograph, but since then there's been accumulating evidence for an association, and this may warrant re-evaluation. It's important to know that all types of alcoholic beverages can cause cancer to the same extent for the same amount of alcohol. And how this is measured is the following. We consider that as 1 unit of measure is 10 to 12 grams of pure alcohol. So a 33 centiliter glass of regular strength beer equates to a glass of wine or a shot of spirits. I must say that today there's a tendency for higher volumes of alcohol beverages, notably in beers, so that the unit measure is actually a smaller volume of a beer at 7 or 9% volume, for instance. So another important point is that there's a common perception that only heavy drinkers are associated, are at increased risk of cancer. However, there's a large number of studies that have shown that this is not the case. For instance, on the right side of the slide, for breast cancer, there is no threshold and the risk increases linearly with the first glass consumed. And this is also the case for cancers of the oral cavity, of the pharynx, larynx, and esophagus. You may know that some people cannot drink alcohol or they have some very unpleasant symptoms such as flushing and so on. And the reason for that is the following. After your first sip of alcohol, the ethanol in the beverage is transformed into acetaldehyde by bacterial enzymes. And some people have a deficiency in these enzymes, and as a result, there's only a residual activity of only 10%. So the acetaldehyde actually accumulates in the body while it's kind of waiting to be digested. And we have just seen that acetaldehyde is genotoxic. So in these people, there's an increased risk of cancer compared to carriers of the common allele of these enzymes. Another important element is the synergy between tobacco and alcohol. Tobacco smoking and alcohol consumption often go together. And the prevalence of ever smoking strongly correlates with the amount of alcohol consumed per day, which you can see on the left panel. And when it comes to cancer, the risk of cancer when smoking and drinking is multiplicative. That means it's more than additive. 2 + 2 = 6. And this has been verified for all head and neck cancers, that is cancer of the oral cavity, the pharynx, and the larynx, for both men and women, for people of all ages, and for populations in several regions, including Europe, North America, and South America. Today, half of the population globally consumes alcoholic beverages, with men consuming more than women. But as we know, there are large regional variations. Among the WHO regions, those of Europe, of the Americas, and of the Western Pacific, which includes China, the prevalence is higher than 60%. It's below 30% in the regions of Africa and Southeast Asia, and it's below 4% in the Eastern Mediterranean region, primarily as a result of the Muslim culture. The per capita consumption roughly follows the same ranking. That is, the amount of consumption is high where the prevalence of consumption is high. In an analysis of the trends in consumption since the beginning of the century, we can observe a sharp increase in consumption in 2 regions, namely in Southeast Asian region and in the Western Pacific region, which are mostly driven by an increase in consumption in India and China, respectively. Worldwide, there are 740,000 new cases of cancer due to alcohol consumption in 2020. Most cases occur in Asia, but Europe also sadly represents a fair proportion given its population. The top 3 countries share 60% of the burden, with China having 4 times more cases than India, the second highest country. These are the absolute number, so one would expect that the most populated countries carry the highest burden. But when we're looking at the population attributable fraction, the Western Pacific region, which contains China, still comes first, but Europe is a close second, with 4% of cancers attributable to alcohol consumption, which is also the world average. Earlier, I mentioned that the risk of cancer increases with the first glass of alcohol, and this is how it translates. When we look at the relative proportion of cancers attributable to drinking by the amount of alcohol consumed, it appears that in all regions of the world, a significant percent of those cancers occur in people who drink moderately, that is less than 2 drinks a day. And this is particularly striking in women, where up to 40% of the cancers are due to moderate drinking in regions such as Southeast Asia, in the Western Pacific, and in the Eastern Mediterranean region. So I said earlier that alcohol beverages can cause cancer at 7 sites. And when we look at the distribution of the 740,000 cases attributable to alcohol, Cancer of the esophagus represents 25% of the cases, followed by the colorectal with 21% and the liver with 20%. Breast cancer ranks fourth with 13% of cases. So I'll now move to the second part of my talk on the IARC Handbooks of Cancer Prevention and on the volume 20 on alcohol control. So the IARC produces two series of volumes on cancer prevention, the IARC monographs and the IARC Handbooks program. The IARC monographs identify risk factors for cancer in humans, and the IARC Handbooks series complements the monographs evaluation for carcinogenic hazards. Typically, agents that are evaluated in the monographs may fuel priorities for the handbooks. For example, as you can see in the images, after identifying tobacco smoking as a carcinogen, the handbooks evaluated the reversal of risk upon quitting smoking. Or when HPV was shown to cause cancer of the cervix, the handbooks evaluated the effectiveness of cervical cancer screening. The process and procedures for reaching these evaluations is comparable between the two programs. IARC convenes a working group of international independent scientists with different expertise. The working group performs comprehensive reviews and consensus evaluations of the agents or the strategies or interventions. And national and international health agencies use the evaluations to develop evidence-based interventions or policy recommendations to reduce the cancer risk at the population level. These schemes present the rigorous and transparent review of the evaluation process performed by the working group of experts. The 8 steps are the following. First, identification of the review questions, and then a comprehensive and transparent identification of the relevant literature, which is done partially by the IARC staff and partially by the working group members. Then the working group, the panel of experts, screens the studies, selects the study and organizes them. Then they extract the information, including all the characteristics relevant to the study quality. Then each study is summarized and evaluated for its quality. And all the summaries and quality assessment are peer-reviewed within the working group and the members of the IARC Secretariat. Then the working group produces synthesis of the results and of the quality of the studies, and this then leads to the interpretation of the study results and the evaluation of the strength of the evidence. And this process is written up in what we call the preamble of the monographs and of the handbooks. So back to alcohol. A few years ago, the IARC Handbooks program embarked on a 2-part volume for alcohol control. And the reason why we did 2 volumes was the following. As I explained, when we have a monograph, we first want to see whether stopping exposure can reduce the risk of cancer. And then we can evaluate whether a policy intervention can actually reduce consumption of alcohol or also for tobacco, for example. So for this 2-part volume, we first evaluated the evidence that reducing consumption of alcohol can reduce the risk of cancer for those sites for which there is an association between alcohol and cancer. So oral cavity, larynx, pharynx, esophagus, the colon, the liver, and the breast. And we then did a second volume, volume 20B, where we evaluated a series of population-level interventions for their potential in reducing alcohol consumption. And these policy interventions were in 3 categories: on tax and price, in restriction of the availability, and in restriction of the marketing. And we actually also reviewed, but did not evaluate, individual level interventions of screening and brief interventions for alcohol use disorder and for the treatment of alcohol use disorders. So this slide gives the number of studies that were reviewed to evaluate the reduction in risk after quitting drinking or reducing its consumption. You can see that most of the studies were on alcohol cessation, and we had only few studies on the reduction and few studies on the time since drinking cessation. And there were several challenges when we evaluated these studies, mostly that studies have evaluated the risk of former drinking compared to non-drinking, whereas we wanted to evaluate the risk of former drinking compared to current drinking. So the working group actually had to recalculate all the values from the different studies. Another challenge was the interference of tobacco smoking. I mentioned that there's a strong synergy between tobacco and alcohol. So even though the studies have usually taken that into account, there's always a doubt of residual confounding by tobacco smoking. A third challenge that the working group faced was that for several organs, the increase in risk upon drinking is fairly small, so it's all the more difficult to show a reduction in risk upon quitting drinking or reducing your drinking behavior. The working group also evaluated the mechanisms by which alcohol causes cancer and which of those mechanisms would be reverted upon quitting or reducing drinking. So I don't expect you to read this scheme in details, but this shows the complexity of the effects of alcohol in the body and the numerous pathways by which alcohol can cause cancer. And among those pathways, the working group identified 7 endpoints for which there was data available upon reduction or cessation of drinking. So now finally, I'll share with you the evaluations by the 2 working groups in evaluating the level of evidence for the reduction or cessation of alcohol consumption and for the policies. So you remember that we first wanted to confirm that reducing or quitting alcohol consumption can reduce the risk of cancer. So this was clearly the case for cancers of the oral cavity and of the esophagus. For the other types of cancer, where you see that there's limited evidence, this was mostly because of the number or the quality of studies, but this does not mean to say that there is no effect. And of all the 7 pathways that were evaluated that I mentioned earlier, the working group concluded that 3 of those are reversible upon quitting drinking, which explains the reduction in risk that we have observed in the epidemiological studies. These results were published as a special report in the New England Journal of Medicine, and the full report, which you can see at the bottom right, is available on our website or in print format from the WHO Press. Regarding the evaluations of the alcohol policy interventions, among the tax and price policies, taxes and minimum pricing were effective in reducing alcohol consumption. Among the policies that reduced availability of alcohol, all of them showed to be effective. That is, the density of sales points, the days and hours of sales, the minimum purchase or drinking age, and the total ban on sales. All of these were effective in making people quit or drink less. Also, strong bans on alcohol marketing were rated as being effective. And we also evaluated a number of studies that looked at the combination of several policies, which we called coordinated multiple alcohol policy interventions. And these studies also showed sufficient evidence that such combination of policies can reduce alcohol consumption. The results of this evaluation were published as a special report in the New England Journal of Medicine on the 1st of June, and the full volume of the handbook will be available online in October 2024, and then also in print. Finally, I would like to give a very big thank you to all the IARC team members who did the work that I've just shown here. Thank you for your attention, and I'll gladly take some questions during the panel session. Thank you.
Thank you so much to Dr. Islami and Dr. Labbe-Secretan for their great keynote presentations. We will now transition to a panel discussion, and I ask our panelists to all turn on their cameras. And while they do that, I'll briefly introduce myself. So I am Katie Winkworth-Prejnar. I'm the director of the global program here at NCCN. And it's really my privilege to moderate today's panel. This topic is extremely timely given recent conversations at the World Health Assembly, the World No Tobacco Day last week, and the upcoming high-level meeting of NCDs in September. And I hope that the panel can build on these great keynotes and further discuss how lifestyle, environment, geography, and policy contribute to cancer risk, and more importantly, what we can do about it. So I would really like the session to be interactive, and I encourage our audience members to submit any questions to Q&A, and we will try to address as many as we can. And since we've already met our keynote speakers, I want to start with our additional panelists. So Ms. Rosales and Dr. Shields, I would love if you could briefly introduce yourself and tell us in a few short sentences why you are on this panel discussing modifiable risk factors for cancer and ways to address them. So Ms. Rosales, how about you go first?
Thank you, Katie. Hi, everyone. I am Man Rosales Santo Domingo. I am a public health lawyer based in Manila in the Philippines, and I'm also the regional manager for Asia of the McCabe Center for Law and Cancer. And thank you very much for including us in this panel for this very important discussion. The McCabe Center for Law and Cancer is the only dedicated center in the world to advance law, to prevent cancer, to protect people affected by it. And we're also the WHO Collaborating Center for Law and Non-Communicable Diseases. And we're so excited to, participate in the discussion today. Thank you, Katie.
Thank you so much, Ms. Rosales, and we're happy to have you. Dr. Shields.
Yeah, hi, everybody. I'm Peter Shields. I'm at Ohio State University. I'm a professor here. My clinical practice is for lung medical oncology. But I've done 30 to 40 years of research in molecular epidemiology, tobacco control, that sort of thing, working on a lot of biomarkers, but behavioral interventions and that sort of thing.
Great, thank you. And you can see we have both the policy experts, epidemiology experts, and advocacy experts. So I want to start with Dr. Islami. I think your presentation really set the stage for the various modifiable risk factors and the importance of prevention for addressing the global cancer burden. And there's a lot of focus on tobacco control policies and the success over the last several decades. I was really struck by the statistic that you said in the US, and in large part due to tobacco control, 3.9 million cancer deaths were averted and 76 million person years of life were gained, which is pretty significant. Despite this progress, you've also said there's been some setbacks and governments are behind on their target measures. And I think things like COVID-19, climate change, budget cuts have further disrupted some of these cessation efforts. So Dr. Islami, from your perspective, what are some key intervention areas for tobacco control moving forward so we can continue to help countries reach their target goals under the WHO Framework Convention on Tobacco Control?
Thank you very much, Katie. This is a very important question because, as I said in my presentation, although we have seen declines in prevalence of smoking, the smoking rate, especially among men in many countries, is very high. Like more than 1/3 of adult men in many countries are still smoking, and in some countries, the prevalence may be closer to 50%. So one thing that I think is important is to know that we actually the interventions suggested by the FCTC, WHO's FCTC, I think they are very comprehensive. The only important thing is that the countries should kind of try to implement them comprehensively. As I said, as I showed many countries have not implemented many of these, because it is important that these policies are implemented together. For example, increases in taxation can reduce the initiation, also motivate people to quit smoking. But we know that also quitting smoking is difficult for many people. So they may have a lot of attempts, but they may be unsuccessful. So in that case, we also need those cessation services like quit lines, counseling and medications when necessary. And in many places, these services may not be available. And especially given that the smoking prevalence is higher among lower income people, that limitation is maybe a major barrier for people who smoke to quit smoking. Warning labels have shown very effective in kind of motivating people to not start or quit smoking and all other things. In addition to that, I think in addition to more commitment to implement this intervention, as I said, there are some population within countries with a substantial decline in smoking that we see a high prevalence, like lower income people in the US or people of American Indian, Alaska Native in the US have higher smoking prevalence. So I think this intervention also should be fine-tuned, tailored, so be more effective in those populations. And I think Dr. Shields can have much more to say about these policies, but that's my point here.
Thank you so much. I'm going to move to Ms. Rosales because I think building on what Dr. Islami talked about, you're based in the Philippines and Asia where we're seeing increases in tobacco usage, but you're also the regional manager for Asia for the McCabe Center, so also seeing a lot of policy implementation. So can you talk about what are the main cancers in your region and how risk factors like tobacco or alcohol impact them? And then second part, what are some of the policy strategies you've seen employed to mitigate some of these risks?
Yeah, thanks, Katie. I was listening to Dr. Farhad and Dr. Beatrice earlier, and it really resonates with us here in the region. So in the ASEAN region, the top 3 cancers for women are really cancer of the breast, cancer of the cervix, and cancer of the colorectal. And for males, it's really the big 3 are still lung cancer is number 1, as Dr. Farhad mentioned earlier. The second is cancer of the liver, and last, again, the colorectal cancer. And you see this connection, right, with tobacco consumption as well as alcohol consumption. And really, you'll see that in ASEAN, we have 10% of the world's smokers still using tobacco and smokeless tobacco products. And 19.1% of adults in the region are actually smokers. And what's even more alarming is that we're seeing that aside from these people who use tobacco, consume tobacco, there is also a very big number that is shifting and adding up to this statistics that are younger people who are now using novel tobacco products and nicotine products, which is again a whole different problem that is beginning or is already here actually. So all of this, including also alcohol consumption that Dr. Beatrice talked about earlier, are some of just the major issues that we're facing in the region. And more, you're seeing policy measures that are being used. And I cannot emphasize this enough that, the effective use of law to be able to create that healthful environment, to create and enable healthy behaviors is so crucial. And in tobacco and alcohol, which are health-harming products, you have all of these tools that you can pull together, like health taxes or sin taxes and excise taxes, as well as regulating the marketing and labeling of these products. So I think we're slowly moving towards regional collaboration also on these aspects. And for one, the ASEAN is one body to start with in terms of kind of connecting everyone and seeing the bigger regional picture to be able to identify opportunities for collaboration in these areas.
Thank you so much. And I think 2 points will go back to the disproportionate impact on youth for some of these risk factors and the importance of policy strategies like health taxes. I would love to take a deeper dive later in the session. Thank you so much. I'm going to move to Dr. Shields because you have had a long career in tobacco cessation and you're a practicing physician in the US. What are the parallels or differences you see with your populations in terms of tobacco use over the last couple decades? Where have we made advances? Where have we kind of had some setbacks? And from your perspective, what can we do as a physician community to try to address some of these barriers?
So there are different issues and ways to address around the world, but everywhere it needs to be addressed. So there's no ambiguity there. In the U.S., my focus has been fostering smoking cessation among cancer patients. The data is very clear that those who continue to smoke, first of all, if they're fortunate enough to be long-term survivors, they're at big risk for a second primary, for a new cancer. Whatever set them up to have cancer in the first place from smoking, there are other cells that are equally on that progress. But it increases toxicities from radiation, from chemotherapies. There's just a lot of data to foster that. The problem is multifold, okay? But really, how do you get them to do it? I mean, everyone in the US, I would say, maybe globally, understands that smoking is bad for your health, but that's not enough. And the teachable moments are often not enough. So they kiss death from lung cancer and survive. They get a heart attack. That's not enough. And so this is really complex. And my focus has been on the cancer patient, but the lessons are really applicable to the person who gets a heart attack or other serious chronic illness. There's just a lot going on in their lives. And the clinicians, whether you're in an area without access to the best therapies, whether you are in the most fancy cancer centers, the focus is not getting them to quit. And that's the first thing. And the training for these folks, a medical oncologist, a surgeon, they are less prepared and less taught how to foster smoking cessation than maybe a family practitioner. But still, they're all overwhelmed. And in those patients, most patients who are smoking, most people who smoke, quit without AIDS, quit because they understand something happens. So it's those that don't are the trickier, harder people to treat, and you need to have some specialty skills. So as part of the NCCN process, we developed these guidelines for fostering that. What's the minimum number of questions you ask? What's the simplest way to really get people to do that? And for the cancer patients, it's a combination of counseling, no matter how brief, and pharmacotherapy, nicotine replacement therapy, other drugs, often not available in other places, but it's whatever you can do. But you're dealing with an overwhelmed population. Cancer patient walks in, they're focused on getting their cancer taken care of. It's sort of like, oh, what does it matter if I continue to smoke? A lot of physicians still think that's not an issue either, and it does. Even for the hospice patient, quitting smoking, improves quality of life, and again, it improves toxicity and or reduces toxicity and that sort of thing. So, with the NCCN process, over the last year, we developed the other half of the equation. So we're educating providers on the best algorithms for smoking cessation. Now there's a patient information thing, because that was half of it, okay? And we were missing half. And so it's really the combination of not only just helping the patient, but for a lot of my patients, they come in with their significant other, with their kids, with their people who they're living with. And one of the key questions is, who else smokes in your home? So now we're doing smoking cessation counseling for everybody. And so I think that's important. The last thing I'll mention is the smoking cessation guidelines have been adopted for global use. And those are available and take into account the varied resources. But it's important for wherever you are on this planet to foster that smoking cessation. And those guidelines, a lot of people said to me, you're focused on cancer, but I use this in my training of the fellows for cardiology and for pulmonary, because the principles are really there, that you don't have the luxury is a really bad word, but you don't have that opportunity to say, okay, let's try this. Then in 3 months, if that's not working, we'll try something else. Then we'll add to it. There's a sense of urgency. So one of the points of these guidelines are hit them hard, make smoking a past medical history for them as fast as you can. And so we do everything all at once in a very comprehensive way.
Thank you so much, and thank you for your leadership in terms of the clinical guidelines and the patient guidelines. I think they're a great resource, as you mentioned, not just in the US, but globally, that can be adapted for specific populations and contexts. And I like your point. It's not just cancer. You know, these risk factors impact a lot of NCDs, non-communicable diseases, and other disease areas. So there's a lot of lessons learned there. I'm gonna focus on something you said, because you said everyone knows smoking is bad. But I want to transition to alcohol, because I don't think everyone understands the link between alcohol and cancer. And in fact, research was just presented at ASCO last week that in the US, a significant number of people do not even know there's any link between alcohol consumption and cancer. So Dr. Labi Sekretan, I thank you again for your great presentation. You know, consumption of alcohol is entrenched in many societies and cultures, and we know that, you know, there is a link with cancer, as the data suggested. From your perspective, what are some messages or strategies to address alcohol consumption and start to begin to address these alcohol-related harms and cancer?
Thank you. So yeah, it is quite frightening, I would almost say, when you see the studies that have looked at awareness of the carcinogenity of alcohol. Depending on the populations, it can be as low as 10 or 20% of the sample, you know, having a vague idea, but yeah, it could be. And then, yeah, but it's just liver cancer in these heavy drinkers. You know, it doesn't affect me. So I think very, very first line is building awareness through campaigns, through medical, I mean, any sort of healthcare providers. Every second is a teaching moment. I tell everyone in the orchestra, wherever I am, I tell people, look, alcohol causes cancer and breast cancer. You young girls, you know, watch out. So I think this is a very, very important aspect. And I think that we've reached a turning point right now that it has kind of come out of the box. I think we can't hide it anymore. It's been known for 50 years, like for tobacco. The alcohol industry has been very good at hiding it, but I think now it's really out. And we must use this momentum to really spread the word. In terms of you know, regulations and so on, we've shown which one work, which one don't. Then I would say it's for each, you know, country or jurisdiction or you know, unit, whatever, to decide what is the most applicable, the most efficient. To use you know, political opportunities, maybe a change in regimen or economic crisis or what have you, to say, right, we've had enough now. You know, let's try and tackle this issue, and let's put in place a very you know, comprehensive, coordinated approach to alcohol control. And this have worked beautifully. Just yesterday, I gave a webinar in the IARC Summer School about alcohol, and one expert from Lithuania shared his experience in how Lithuania was able to reduce it. They were #1 consumer in the world of alcohol, with like, I don't know how many liters per day I mean, just insane numbers. And they had a very, very effective policy that has really shown its effect. But what was interesting was they also showed not just put them in place, but maintain the effort. Constantly maintain the effort. So these, I would say, are the two key messages I want to bring to this audience.
Thank you so much. Dr. Islami, being at the American Cancer Society and, you know, one of the largest cancer organizations in the US, does ACS have any communication strategies or other initiatives to start to tackle alcohol consumption and the risk of cancer?
Yes, would like I've been invited frequently to talk about the harms and especially increased risk of cancer associated with alcohol. So I think my colleagues at the advocacy part of the American Cancer Society, called American Cancer Society Cancer Action Network, they are reviewing the evidence, and they may be coming with more actions in the future. But currently, what we suggest as part of the American Cancer Society dietary guideline is that it's best not to drink alcohol. And if people choose to drink alcohol, it's better to limit it to one drink per day for women and 2 drinks per day for men. Which this may also be changed in the next dietary guidelines. But for now, the recommendation is best not to drink alcohol.
Thank you so much. Ms. Rosales, what about the McCabe Center? I know a lot of your work historically is focused on tobacco cessation, but anything you're working on in terms of alcohol consumption?
Yes, definitely. Actually, currently, we're developing a policy brief on law and alcohol to support countries, think about what policy regulations and what laws should be in place, and enabling mechanisms that should, bring everything together, bring everyone at the table to be talking about laws around alcohol. And so we're doing that in our wearing our hat as the collaborating center for law and NCDs at the WHO, and we hope that this policy brief can help support countries as well as advocates on this aspect. And I wanted to just also touch on what Dr. Lobby Secretary mentioned earlier about raising awareness, and I think that aside from raising awareness among consumers, it's also so important for us to raise awareness of policymakers, right? For people in the room who make the decisions around these laws and around these policy environments, to be aware of the risk related between alcohol consumption and cancer, so that people can come together. And now we're seeing that in effect, like in Ireland now, of the warning labels of alcohol consumption and cancer. And although all eyes are now on Ireland on how this is going to be implemented in 2026, I think it's a big opportunity for everyone to build momentum on this matter.
Thank you so much. Yeah, and educating policymakers is a key part. Dr. Shields, I want to move to you because the ASCO abstract also surveyed people on if their health practitioner talked to them about the risk of alcohol and cancer, and very low numbers. I think it was in the teens reported that their physician had talked to them about the risk of alcohol. Anything from your perspective, anything you implement in your practice or what you're seeing in terms of physician education of patients on these risks?
So yes, for smoking, there's a lot of data that shows almost crudely, as long as the provider says something, that means a lot. And so the best counseling is with motivational interviewing, and you got to be trained to do it, and it's multiple sessions. But there's actually a lot of data that says even 2 to 3 minutes of counseling is better than no counseling. So if you just sort of tell someone to take nicotine replacement therapy and you don't do any counseling with it, it's a lot less effective than if you do some counseling. And so that's so that's critical. But a lot of physicians don't, and that's really part of the problem. Or I shouldn't say just physicians, it's any healthcare provider, the nurse practitioners. Best practices have actually been defined, at least for the US, and that is for the cancer patients where they are automatically referred. It's an opt-out system, as opposed to saying to someone like, would you go for this, or would you call a quit line? Because a lot of these patients don't. They just never show up. So an opt-in system that triggers stuff is a lot better. Obviously, there's more resources. In the US, the reimbursement for smoking cessation services stinks. And probably in large parts of the world, there's none. And that's another part of the problem. So physicians know they should be doing it. Healthcare providers know they should be doing it, but they don't way too often. And that's one of the reasons why we developed the guidelines, is because from NCCN, is we wanted to say to at least the medical oncology or the oncology community, surgery, medical radiation, standard of care includes fostering smoking, smoking cessation, as a very direct statement. And so that's where we are today, but still too many people don't adhere to it.
I want to stick with you for some follow-up questions we're getting from the audience. So historically, tobacco has been what we thought about as cigarettes, but increasingly vaping, e-cigarettes have really consumed the market and have been a little outside of traditional tobacco cessation efforts. So can you talk about kind of the impact of these new smoking methods and ways that we can help address, especially maybe for younger populations?
Do you want me to take that?
Why don't you start, and then I'll go to Ms. Rosales.
So this is a very complicated question, because there are some people who believe that electronic cigarettes and vaping are the worst thing you can do, and it's as bad as smoking. And other people think that this is a great smoking cessation tool, and that they're worried at the same time about kids who uptake that. And so across the globe, the policy, the regulations vary from places in the UK where it's considered clinically acceptable as a smoking cessation tool, to Australia where you can only get it by prescription, to some countries that ban it, to the US where it varies in terms of policy by state and city. And it's really interesting because everybody's looking at the same data, but they're interpreting it differently depending on what their concerns are. And so there's more than enough data to say that vaping fosters smoking cessation. I think there's more than enough data to say that vaping is safer than smoking. Now, I'm not saying it's safe, but on the continuum of things, it's probably better to vape with a plan to transition off vaping like you would transition someone off of NRT. Although I know very, very smart people who say, why would you move them off of vaping? Because maybe they'll go back to smoking and it's not worth the risk. And so that's in my mind, a good problem to have. I think what's happened in the United States is that there was a very rapidly growing epidemic around youth uptaking vaping. That has seemed to slow down. I think that's a separate issue than deciding what to do for vaping among the smoking patient. And the NCCN guidelines, we have had multiple discussions every year, every time we meet, on whether in the continuum of just say it's not evidence-based for vaping, we don't know the long-term effects, it shouldn't be used, to it should be one of the primary treatments. And we have evolved. And it used to be that now if a patient wants to vape, back then we were like, just tell them it's not evidence-based. Now it's more like, work with them. And if that's really the way they're going to quit smoking, that's better. For me, for lung cancer, I don't want anything going into people's lungs. Okay, but for other cancers, that might be different. And we're starting to see now associations in the US and in Canada starting to think about vaping as one of the tools to help people quit. And there's data for that it may be better than NRT, nicotine replacement therapy. Again, when you read the papers, there's no really good definitive study. And so it depends on whether you want to look at the limitations more than not. But around the world, there is no consensus on how to deal with vaping and the risks in terms of a precautionary principle, prevention of other damage.
Thank you so much. And Ms. Rosales, I want to, if you don't mind, quickly go to Dr. Labbe-Secretan from the data piece. So IARC's position on the use of vaping and the health risks and any kind of, if you're comfortable answering that, how do your handbooks address this issue?
Okay, yeah, I'll respond what I can, which is very little. So, as you know, IARC is mostly in research on prevention, and the monographs in the handbooks are based on available studies. And it has been selected as one of the agents of high priority for the IARC monographs in terms of evaluating the evidence that e-cigarettes can cause cancer. And then we would have a handbook on saying whether reducing the consumption of, the use of e-cigarettes would reduce your risk of cancer if there was one available. Now, whether we would be evaluating whether it helps in reducing smoking is actually an interesting question because it would be not quitting, it would be quitting smoking, but by using, something else rather than quitting, so it would be switching. So great question. Thank you for that. And I'll keep it in my mind. Maybe in 5-10 years time, we'll do a handbook on that. Maybe it's too late, but I think it's never too late. Thank you.
Thank you so much. And Ms. Rosales.
Yes, thank you, Katie. I just want to say that, yes, correct. It's never too late. But besides, the fact that there is in fact no, the WHO itself says, that there is still no strong evidence to, kind of put together all of the findings and say that vaping and e-cigarettes are harmful to health. There is, however, a call to action issued by the WHO to, for countries to take action on the alarming intake of e-cigarettes specifically by the younger population. And this WHO call to action document shows that, the FCTC, the WHO FCTC can actually be used by countries as guidance in terms of regulating the commercialization of these products. Because at the end of the day, these vape products, these e-cigarettes contain nicotine. And the WHO FCTC touches precisely on nicotine addiction. And so the mandate provided by that treaty, signed by countries, covers also all products that contain nicotine, and which includes e-cigarettes. And just going back to, my part of the world here, it's really, really alarming because we see younger people taking on these products and using these products. I have young kids. I have just a boy who just turned 9, and we see young people as young as 9, 10, 11, on the streets trying these products because of the appeal of flavors, etc., and the coolness, of these products. And so it is something that countries should be able to look at and regulate and tread carefully rather than more loosely. And so just again on the WHO call to action document, it specifies 4 key actions already, which is 4 countries where the sale of e-cigarettes are banned. The WHO calls on them to strengthen the implementation of this ban and to continue monitoring and surveilling, public health interventions to ensure the strong enforcement of these laws. And where countries already permit commercialization of e-cigarettes as consumer products, the WHO calls on these countries to start ensuring or putting in place stronger regulations to reduce their appeal and their harm to the population. The third is preventing initiation of users or first-time, users of vape and e-cigarettes to not take them on, because even if there's no clear evidence yet on the long-term effects of these products, what we see is that younger users of vape and e-cigarettes are more likely to take on and to try tobacco products. And so we see the connection there. So irrespective of whether countries ban the sale or permit commercialization of these products, they should prevent initiation of the use of these products. And lastly, countries should not pursue a smoking cessation strategy that permits commercialization of e-cigarettes as consumer products. So these are just some clear guidelines and the framework that countries can look at to be able to have a clearer grasp of how to regulate and manage the flow of these products in the market.
Thank you so much, and really practical policy suggestions and recommendations. Dr. Shields, did you want to contribute? And you're on mute.
Yeah, so those are all really, really important points. And I think the struggle within these policies is looking at these products as a continuum of harm. So yeah, we want to avoid, my own personal opinion, nicotine uptake by everybody, okay, which is really a disease of youth, right? That's what nicotine addiction more is, right? And so how do we foster helping the smokers that are using the products that are the most harmful and transitioning them down to a lower level? And it's really hard to capture that in policy. And policymakers, like the folks on this panel, have to make decisions. They don't have a choice, and we don't live in a perfect world. And so how do you cover the greatest part of the population, maximize your impact on the population within that continuum of harm? And that's the challenge we have. And that then goes from vaping to now these oral nicotine pouches, which may not be much different than nicotine replacement therapy, but marketed in a very sexy, appealing way to non-nicotine users and that sort of thing. And we're starting to look at that as yet another challenge on this continuation of harm paradigm.
Thank you. Yeah, very, examples of policy in real life and merging the two together. Building on this idea, I want to move to kind of commercial interest, because there's been a lot of focus recently on industry's tactics for manufacturing and advertising its products, not just tobacco, but alcohol, fatty foods, things like that. This was a big piece of the World No Tobacco Day. And PAHO actually just had a webinar yesterday talking about this. Some are calling it, I think, commercial determinants of health. So this question is open to anyone, but can you discuss commercial interests, tobacco, alcohol, food industries, and their role in promoting some of these risk factors? Anyone want to tackle that? Dr. Shields?
Yeah, I guess I'll start. And in full disclosure, over many years, I have participated in the court system in a lot of our lawsuits against the tobacco industry. And the tobacco industry in the US globally has a long history of trying to promote their products. It's capitalism. And so they have for many 30, 40, 50 years have always said they're always interested in health and not hurting people. And now it's just expressed differently. But it remains a huge issue. So there's a part of us that think that some of these tobacco companies are buying the electronic cigarette, manufacturers is more because they could say they're promoting a less harmful product. It gets very complicated, but here in the U.S., we see the lobbying forces, just as strong as ever, with all the things that Dr. Islami talked about in terms of tobacco control. They're fighting every corner of it. And in 2009, when the Congress gave the FDA the authority to regulate tobacco products, I'll give a very personal view that I've said to other people, is, we all thought that this would be the tobacco endgame, that this would be FDA get control, tobacco would go down. In fact, that's not been the case. It's sort of like, I'll say facetiously, who knew government moves slowly? But more so now with what's going on in the government, the FDA is being totally gutted for enforcement of tobacco policy in many different ways. So we have particular concerns that whatever gains we have may not, but that 2009 legislation had a line in there that said, the government could not ban smoking or nicotine. And there's a very good policy about reducing nicotine in cigarettes that shows to be effective, which I think the industry knew that would never see the light of day in actual regulation. And so basically, it allows smoking to continue in this country unabated, and the industry to be able to do whatever they want in terms of their lobbying efforts impacting policy. So we had a good law that was supported by at least Philip Morris and some of the other tobacco industry companies, and we probably should have been more suspicious at the time about why they were supporting it.
Thank you so much. Dr. Islami, any thoughts on kind of the food industry and their commercial interests in terms of promoting their products and the link with cancer?
I think, well, we see very kind of a lot of similarities between the tactics that different industries employ to kind of increase their sales. And another thing that I wanted to mention also, in addition to what Dr. Shields and Dr. Rosales said, is that the litigation issue. You know, even a country wants to implement a policy to reduce smoking or something, tobacco country, they have a very strong, and they have a lot of resources to kind of take that policy to the courts, and at least either kind of at the end stop that policy to be implemented, or at least delay it for a long time. So that's, I think, especially in lower income countries, when you know that there may not be enough resources to kind of fight against those efforts from tobacco industry, that's a huge issue. But again, with regard to healthy diet food, I think there are some food products that are kind of relatively different. We know much about their effects, like sweetened, sugar sweetened beverages. You know, they are not nutritious at all. You know, so this is easier kind of. So many countries have started taxing sugar sweetened beverages. Even some local jurisdictions here in the US have started doing that. And it has resulted in reduced consumption of those beverages in those areas. But still, we need more studies to study the effect of those policies on reducing excess body weight and maintaining healthy weight. The same maybe with many kind of ultra-processed foods. But another issue is that, you know, for even having a lot of nutritious foods, also, if the calorie intake is too much, you know, that also increases weight and results in excess body weight. So it's the food part is a more kind of a little bit more complex. And yeah, so yeah, but the tactics from the industry are, I think, that we can see a lot of similarities.
Thank you so much. Ms. Rosales?
Thank you, Katie. I wanted to add to that, and I'm glad, you know, that both Dr. Shields, Dr. Islami talked about legal challenges. And, you know, you see that there is really a conflict of interest here in terms of the industry's interest for promoting products that are, in a way, you know, we can categorize as health-harming products. In tobacco, the line is so much clearer, because really we know the effect of the product. The product was designed to, you know, to kill. So it's a much more different conversation when you're talking about food, and you're talking about sustenance, and you're talking about adequate nutrition. But and we're seeing that conversation play out in food policies in terms of labeling. And now there is a big momentum on you know, countries trying to determine what the appropriate labeling scheme should be for front of pack labeling in their countries. And we're seeing that the industry is taking a position as to what kind of labeling schemes are, you know, a balance of the interest of promoting healthful products and also reducing consumption of ultra-processed food. And the industry has taken a page from the playbook of the tobacco industry, and has taken, you know, countries and governments to court, not only in local courts, but also in the World Trade Organization. And they have placed objections and oppositions as to, for example, I'm talking about mandatory warning labels, those diagonal labels that you see on the front of pack. And they've taken that to court in many different platforms in many countries. But time and again, so much so similar to the story of tobacco, we're seeing that, one, litigation is a tactic. You're going to be litigated. Second, help is always there. And the evidence is always on your side. And public health, at the end of the day, is always going to be a priority or going to be prioritized over commercial interests. And so if the industry is really, sincere in, cooperating and trying to build a more healthful environment, it has to think about its impact on health. Not only on health, impact on environment as well, right? So all of these things are integrated. Thank you, Katie.
Thank you so much. And I think this idea of unhealthy foods and excess body weight is really going to be at the forefront in terms of global public health. I read a stat that unhealthy weight is projected to reduce the global economy by over 4 trillion a year by 2035, and obesity is set to become the leading risk factor for cancer, surpassing smoking. So I think it's really important we learn from kind of all the great progress in smoking cessation and apply that to these other areas. So I want to address an audience question, and I want to make sure I phrase this correctly. So there's this idea that tobacco and alcohol and food are a choice. So you choose what these things. And I know there's a lot of disparities and we can address that later. But why is there not the same amount of attention given to carcinogens that affect our health that we do not choose? So toxins released in the air from climate change, unhealthy additives in our food that we might not realize. So open it up to the panel if anyone wants to talk about kind of these other areas that are really important but might not get as much attention, and what kind of audience members or other global health specialists can do to make sure that these are part of the agenda and discussed. Dr. Islami, I'll start with you.
Yeah, I can start. Actually, in one of my first slides, I showed the proportion attributable to air pollution and occupational exposures. But because this webinar, especially the 20 minutes that I had, it was not much enough time to cover everything. So and the focus was on kind of more behavioral things. So I didn't talk about them, but they are very important issues. I would say that in the US, about 80 to 85% of all lung cancer deaths, which is the leading cause of cancer in the US, are attributable to smoking. But like remaining about 15 to 20% can be attributable to other modifiable risk factors. Residential radon is one of them. In addition to that, the air pollution is one of the risk factors. So in addition to causing lung cancer, air pollution can also cause other respiratory diseases like asthma, COPD, or something. So they are very important issues. And I think we need more efforts, policies to kind of reduce those exposures, and especially in some countries, it may be that the exposure to these kind of environmental factors can be even worse. And these exposures are usually affects more lower income people, because if you look into that, around the factories or something that may make a lot of air pollution. The residential areas around those factories are usually kind of inhabited by lower income people. So I think that's an important issue.
And Ms. Rosales, anything from a policy point of view?
Yes, for sure. So I just wanted to touch on 2 points first from the question. So first, the participant asked about, what do we do about unhealthy additives in our food? And I think it's not often as clear at first to see that healthy food policies have a range of interventions. It's not just reducing obesity and overweight, but also protecting food safety, for example, and its effect on the body in so many different levels. I'm not going to pretend to be an expert on the medicine because we have our experts here, but that is exactly why the WHO recommends a range of best buys under each of the risk factors. So we cannot definitely make a dent on the cancer burden or the NCD burden if we're just going to focus on one intervention. All of these interventions have to be working together. So earlier, Dr. Islami mentioned about trans fatty acids, and that is one kind of additive that has often, been out of our perspective for a very long time. And now, because of the spotlight on it, trans fat elimination is well underway. And so we hope that this builds momentum on all the different factors. The second point of the question is with regard to air pollution. And air pollution is one of the major risk factors in our 5x5, right? Table of risk factors for NCD. Now, especially, I think the question is so relevant today because it's World Environment Day today. And we're talking about climate and health together. There's no way that we can talk about climate without thinking about health as the heart of environmental policies. And we cannot talk about health in the same way if we don't talk about the air that we breathe. And so I hope that, one key takeaway from this whole discussion is that the law can provide an enabling environment for all of these risk factors to be talking to each other and all of these risk factors to be addressed together. Because definitely there is no one silver bullet that can solve, our problem. But if we all work together, I think we have a chance.
Thank you so much. And I want to shamelessly plug that our next global policy webinar will be on the climate and the impact on cancer care. That will be in November. So we'll talk about that in closing slides, but I think this fits nicely to some of those concerns in terms of toxins in the climate. So we've touched on this a lot, but I think cancer prevention is clearly not equally accessible to all. And in terms of low-income settings, in terms of education, in terms of gender. So how can we address inequalities in prevention and policy efforts that really tackle these inequalities? And I'll open that up to anyone that wants to tackle it. I know it's challenging.
I can try to start because thinking about social inequalities is so important because we don't all of us are situated differently and all of us have different capacities to access not only prevention but healthcare in particular, right? And I think at the heart of this conversation is human rights and social protections. We cannot be talking about the problem of obesity or the problem of tobacco use, alcohol consumption, or even climate without talking about basic human rights. And there are international legal instruments that kind of provide this umbrella of protection as well as a minimum or a floor for all countries to provide the basic social protections as everyone's human right. And this, kind of provides us with, again, a fighting chance to kind of have better access to healthcare, have better access to all of the prevention strategies and interventions that are available. And I think one very concrete, very practical illustration of this is universal healthcare. There's been a lot of talk about UHC over the past years, and there's been a lot of action and movement moving towards it. But although high-income countries and middle-income countries are moving slowly towards completing this picture of universal healthcare, what we're not seeing is that we're leaving others behind. In fact, low-income countries have barely moved in terms of social protections, in terms of improving universal healthcare. And so I think that's one very important point to highlight here.
Thank you so much. Yeah, continuing the priority of universal health care and also the human rights framework is really important. There is an audience question that I want to address, so I'll read it out loud. In countries where the alcohol and tobacco industries play a significant role in employment and revenue generation, what proven strategies have helped policymakers balance economic interests with the urgent need to protect public health through stronger regulations? Dr. Shields, do you want to start us off with that?
Sure, I can't address the alcohol part of it. To me, that's more complex, but maybe that's because I'm not the expert in that area. Tobacco, it's a seemingly tough sell to legislators and governments that that fostering smoking cessation is good, but the data is pretty solid, and it's not just improved mortality, decreased morbidity, decreased healthcare costs. That to me seems a little bit more abstract to some people because it's measured in studies, but it's harder to express. But there's also a lot of data that just shows that workplace productivity goes up. Workers are taking less breaks, they're taking less days off for illness and colds and that sort of thing. And so I think it's the balance between getting enough employers and businesses who also lobby behind it. I mean, a great example would be, although not about employment in the industry, but just the whole banning smoking on airplanes. The industry fought it like crazy, and then it turns out that it was a big bonus to them on fuel and that sort of thing by banning smoking on airplanes. Cigarette taxes, again, that's often fought, and the data is pretty clear that a lot of it does help some smokers quit, but other smokers can't quit, and so they start paying more taxes, and it's a bonus in terms of revenue, not decrease. I've done a lot of work in indoor air laws, and a lot of these restaurants and bars come up and say, I'm going to lose all my best customers are the smokers. And the answer would be, well, how do you really know that? Because you haven't had a ban. And as it turns out, people who smoke, when these bans go in, get mad and they don't show up, and then they want to go back to the bar. And they have their own. This is going to be sort of more crudely stated, but they actually meet other people who are smoking because they're all outside the bar, finding like-minded people. And so the revenues to the bars, the restaurants don't go down, and it turns out that they have cleaner establishments, and importantly, the people who worked in those restaurants and bars now have a healthy environment.
Great. Thank you so much. One thing I just want to tackle before I get to our final question, and we've mentioned it, but the importance of health taxes. And I think this is really on the center stage in terms of the high-level meeting on NCDs that's in September, and really being proposed as the best strategy to tackle some of these risk factors. Ms. Rosales, can you describe just generally what are health taxes, and where does the money go, and how do they help address some of these risk factors?
Thanks, Katie. I'll talk specifically about the situation here in the Philippines, about how health taxes were developed and how it's being applied. So health taxes in the Philippines cover health harming products. So we have a tax on tobacco, we have a tax on alcohol, and we also have a tax on sugar sweetened beverages. And all of these taxes are actually applied through the implementation of our universal healthcare law. And in fact, the universal healthcare law is being applied in tandem with our National Integrated Cancer Control Act. So they're working together, and both of these laws draw funding from revenue generated through the health taxes. And also, I just wanted to touch on the cost effectiveness of health taxes, because we know that specifically to the situation of tobacco tax, we know that an investment in tobacco taxes of $1 actually generates a revenue of $7. So it's sevenfold when you reap the return of investment that's put into measures or fiscal measures such as health taxes. And so I think this is one, kind of a good slap on the wrist on the effect and the impact that that people suffer from these health harming products. Because aside from reducing consumption of these products, we're also increasing revenue that's used for healthcare costs and also increasing health outcomes.
Thank you so much. And I can't believe it, but we're almost at time. So I have one more concluding question. And I want to challenge you all to keep it to 2 sentences or less and try not to repeat what someone else has said, if possible. And I know Ms. Rosales said there is no one silver bullet, but I want you to pick one concrete policy or practice recommendation you believe could significantly reduce cancer risks in the next 5 years. And I will start with Dr. Labi Secretan. So you have to think on the fly, but you get to go first. So you can't repeat anyone.
At least I won't repeat anyone. My first choice would be education, public awareness.
Perfect. And very succinct. Dr. Islami.
Yes, I think given that although we have seen increases in the burden of cancer attributable to obesity, excess body weight, and diet, still tobacco is the leading cause of cancer deaths globally and in many countries. So I would say it's something to reduce tobacco use, especially like increasing tobacco taxation will be important. And it's not the increase should be high enough to reduce smoking. We have, for example, in the state, we have excise taxes ranges from 17 cents per packet of cigarette in Missouri to more than $4, $4.50 in New York State. So I think we should need to do something to reduce smoking.
Dr. Shields.
So there's 2 things. I think within 5 years is a really tough goal. Among the policy things that I think will never get enacted, but the data is pretty overwhelming, is low nicotine cigarettes, getting them below addictive levels so that it's not an adolescent issue anymore, and it fosters a lot of people to quit. I think the data is pretty good around that. I think as a long-term game, I love the policies that are just making it illegal with successive generations. So anyone born after 2009, for example, it's always illegal to purchase whether you're 50 years old or 30 years old. And that might be a good long-term way of phasing this out.
Great. Really interesting. I hadn't heard that suggestion. And last but not least, Ms. Rosales.
Thank you. I was going to say that it's the effective use of law to prevent cancer, but I'll be more specific. And I'll say that it's the need to establish laws and policies around conflict of interest. Because industry will use all of its power to, interfere and influence the policymaking process, whether it's at the point of development or it's at the point of implementation. So I think the first clear step that we need to be doing is to protect the policymaking process and the policy implementation process. And you can do that by establishing clear safeguards in the law.
Thank you so much. So I want to really sincerely thank Ms. Rosales, Dr. Islami, Dr. Labi Secretan, and Dr. Shields for all sharing your insights and expertise. I know I learned a lot today, and I hope we can use some of what we talked about and implement it into practice and really help reduce the significant and growing cancer care burden worldwide. So now I want to hand it over to Matt Izzo to end with just some concluding remarks.
Thank you, Katie. So hi, everyone. My name is Matt Izzo, and I'm a specialist in global policy and strategic alliances at NCCN. I'd like to thank you all for your time and participation today, as well as a big thank you to our presenters and panelists, and Katie for moderating the discussion. I would also like to thank the following supporters. Without your support, we would not be able to have these important discussions. This webinar, as well as future and past webinars, will be on our website at nccn.org/global policy. And as Katie mentioned, the fall global policy webinar topic will focus on the impact of climate change and cancer care globally. And this webinar will take place on November 6th. So please be on the lookout for more information there. As Dr. Denlinger mentioned in her introduction, there are also some resources on nccn.org regarding the topics that were mentioned today, including patient guidelines on quitting smoking and survivorship care, smoking cessation, and survivorship clinical practice guidelines. And finally, I would like to mention the NCCN Global Academy as a save the date. This is a live virtual event for excellence in leadership in oncology, and it'll focus on HIV and cancer care and take place on September 23rd. So again, please be on the lookout for information on that. And with that, I want to thank you so much again for your time and have a great rest of your day. Thank you.